Hello,
Hello.
hello. Welcome, everyone.
We are live. Liz, are you at
We
like a
are,
different location or conference
I
or?
am sorry. Yep, exactly. I have a board meeting, so I'm at a hotel. So I found a random conference room. It's very dark, so sorry, guys, but here we are. This is life. Hi, so good to see y'all. I'm on. I feel like I'm so excited to be with some of the greatest people who I love and who are so fun. And it's going to be. I'm just so excited for today's stream. Give us a little update, Chris. How are you? Lauren, Evelyn, how are y'all? How's weather where you are? Give us some updates.
I'm good. It's not raining anymore. It was like raining like crazy. Just busy. So OCD SoCal, we have a big conference this Saturday, a speaker series in Costa Mesa at the Costa Mesa Marriott from 10 to 2 or 10 to 3. We extended it an hour this year. So right now we have about 180 people signed up, and we usually get some people at the door. So it only can hold 200. So we're hoping to get about 20 more people, but we're super hyped about that. We're also going to be showing a screening of the movie Exposure. So if you come to the event, you can stay after and see Exposure. And then on Friday, there's another film that the IOCDF is going to kind of do like the Q&A after. So I'm doing the Q&A for that on Friday. So there's a lot of OCD films out there. There's a lot of things going on. So I'm just busy, but excited to be here and excited about this topic. I always like the topics where I feel like I'm going to learn some new stuff, and I feel like I'm going to learn some new stuff for this one. How y'all doing?
Doing well. We just ate a ton of cupcakes because we just threw a baby shower for Evie and another staff member. When we played a great game of who would be more likely to embarrass their kid in middle school or join the PTA. So it's been a fun time.
Yeah, it is rainy and yucky up here in Rochester. But yes, we are celebrating an upcoming maternity leave for me and getting lots of calls from DBT group members because the work never stops. So I'm actually sitting out of a group to be here. Yeah. So happy to be
well, we are so excited to have y'all. Sorry that it's gloomy and rainy there. It probably is the same outside wherever that is here in Houston. But we're so excited to have you guys. I know that one of the things Chris and I talk a lot about, I was actually having a conversation yesterday. I got a call from a mom who has an adolescent who has been self-harming and has OCD. And the mom was like, I really need to know where to go for OCD treatment. And I was like, honestly, like, it sounds like your child needs DBT treatment first. And so this is a question that we get a lot of, like, how do we know where to start and what it looks like? But then also, like, how does OCD treatment and DBT go hand in hand? So like ERP and DBT intersection, but also how do we know what we need? And how do we make sure DBT doesn't become a safety behavior or ritual, right? Like, how are we using it for what it needs to be used for and still using OCD treatment where is needed? So we have so many questions, so much stuff to cover. We're so excited. I'm going to let Chris do introductions of y'all and your amazing work and background, which I've already learned so much from the both of you in your work. So I know today's going to be really fun and exciting. And quick disclaimers that we always have to go through. Just a quick reminder for everyone that this is intended to be educational, and hopefully our goal is that we can always offer some support along the way, but this is not intended to replace therapy or individual treatment. We are not, and the IOCDF is not a crisis hotline. So if you're feeling unsafe or suicidal, please call 988 or visit your local emergency services. As always, you guys can put comments throughout today's live stream in that pane that you see on the right-hand side of your screen. Please let us know questions you have, things you want us to cover, what we want to make sure we're addressing today so that we can do that together. Chris, I'll let you take the lead.
Yeah, well, I'm so excited to have both of you. I always like to introduce the guests, and then I'll let you, Lauren, talk a little bit about the topic. But first of all, Liz and I, so we are the hosts of Ask the Experts and Lunch and Learn. We're both clinicians. She's in Texas. You could kind of tell by the accent, but you don't really have that much of an accent. And I'm from California, which I get told I don't have an accent, but I say like a lot, which we do in California. So I guess that's my accent. But our guest today, we have Dr. Lauren Wadsworth, who is a clinical psychologist passionate about expanding access to evidence-based treatments for OCD and other anxiety disorders. She's the founder and director of Genesee Valley Psychology, GVP, a clinic providing financially accessible evidence-based treatment to the Rochester, New York area. She is also the founder of Meridian Psychology Practice, where people in New York, Massachusetts, Massachusetts, and Georgia can receive treatment for OCD, BPD, and other disorders within a week of contacting the clinic. She is the co-founder of Twin Stars Diversity Trainers, a consultation company offering diversity and identity-related trainings for organizations and leadership. Finally, she is a clinical senior instructor in psychology at the University of Rochester Medical Center. So welcome to the show, Dr. Wadsworth.
Thank you. I'm really excited to be with you both today.
Perfect. And then Dr. Evelyn Meier Lynch is the director of the DBT program at the Genesee Valley Psychology in Rochester, New York. GVP's DBT program is one of the few comprehensive full model outpatient DBT programs in Western New York that accepts insurance. Dr. Lynch is a DBT Linehan Board of certified clinician, little tongue twister there. She provides rigorous training to predoctoral and postdoctoral therapists who are learning to deliver adherent individual and group DBT to adults, adolescents, and families. Dr. Lynch also maintains private practice through Meridian Psychology Group and specializes in treating adolescents, adults, parents, and families struggling with BPD and severe emotion dysregulation, along with comorbid PTSD, OCD, eating disorders, substance use, anxiety, and mood disorders. Dr. Lynch is an adjunct assistant professor in psychology at the University of Rochester. So two very, very accomplished individuals. Thank you for being on the show. We're excited to have you.
Excited to be here.
Yes. So if you could jump in, Lauren, a little bit about the topic. You know, what people might not know on the back end is a lot of times we reach out to people that we really want on the streams. And we always ask you, or you all tell us like what you're really passionate about. And obviously we're going to be talking about the intersection of OCD and BPD. We're going to be talking about DBT. And to some people, that's a lot of alphabet soup. So can you tell us a little bit about the topic today and just why both you and Evelyn are passionate about it and how come it's important to the people watching?
Sure. So maybe it's helpful to give a little background about how Evie and I met. I had started GVP back in 2019 and it was mostly focused on OCD and trauma treatment and the overlap of the two. And we kept having experiences of folks coming to us for treatment for severe OCD or PTSD and really needing DBT skills at some point in the treatment. Maybe it was right off the bat, like Liz was mentioning, or later on in treatment once the OCD had resolved or the trauma had resolved a bit. And so we thought that we were doing DBT by starting a DBT skills group where we would introduce DBT skills every week, but felt like it wasn't enough and we didn't have anywhere to refer people in our area. And then Evie wrote us an email, appeared like magic out of the sky saying, hey, I've always wanted to do DBT and would love to do it in Rochester. And could we collaborate and do it at GVP? So it was like the best case scenario. It was such an unmet need that we had, and we were really struggling with a bunch of cases. And Evie wanted to start a comprehensive DBT program. So we quickly learned that we were not doing DBT, that doing DBT means phone coaching, 6 months of group and individual therapy. And Evie is someone that knows how to do the full model. So she has trained countless practicum students, postdocs, psychologists, LMHCs to deliver this treatment that has been such a nice addition and something that's really been life-changing for our clients. And we do a lot of work across teams. So having someone that's on the OCD track that then goes to do DBT or vice versa. We also talk a lot about how we can do ERP in the context of DBT because it does have exposure in the model. So that's such a beautiful, wonderful thing. So having these two teams within the same clinic has really worked well, and the treatments do align pretty nicely.
Yeah, and can you tell us a little bit about that? Just like the overall principle, Evie. Do you like Evelyn or Evie better?
Evie likes Chevy.
Oh, Evie likes Chevy. We have a board member, Evie Gould, on OCD SoCal, who's well known in the community. So I was like, Evie likes Chevy. I'll never forget that. Can you tell us a little bit, and people watching, the overall concept of dialectical behavioral therapy, because a lot of times when I'm working with a client with OCD or BDD, they're like, what is the basic concept of the model of the treatment that we're going to be doing? So just giving a little bit of oversight. And then maybe a follow-up would be, how can that be helpful for people struggling with OCD as well?
Sure. So I will answer it in two ways. One is how I might describe it from like a philosophical standpoint. So it was designed to incorporate a dialectic of acceptance and change. So incorporating the more change-focused components of CBT and bringing in mindfulness and acceptance, which at this day and age is a little bit more common in many of our CBT models and in ERP. But back in the 90s, when Marshall Linehan was developing this, it was more of a novel approach. So this dialectical balance between an acceptance and change approach underlies how we develop the skills program. So we have about half and half of acceptance or change-based skills. And it also infiltrates how we run individual sessions. So making sure there's always a balance between change and acceptance approaches. I think a fundamental aspect that's comes to mind when I think about this conversation is that DBT is also a comprehensive model, which means that to do the comprehensive program, you have an individual therapist, you have DBT skills groups, they support each other. So you are learning a whole bunch of skills in the skills group, and then you're having them tailored and customized to your unique problems. You are working with your individual therapist to understand the exact factors that are leading up to your problem behaviors and which skills from that big grab bag that you learned in class are going to apply to your situation. You're getting in the moment coaching 24/7 between session coaching to help generalize those skills into your daily life. And therapists have support in the terms or in the form of a consultation team. So those are the four components. And I feel like that is very relevant because many of the folks that we get from the OCD track, or when OCD practitioners are feeling lost and wanting our DBT team support, much of it comes because there's a lot of different problems and a lot of complicated disorders. And the comprehensive nature of it, I think, is really an important piece of what helps organize the treatment and provides all that extra support through the skills and the coaching.
And I love the way you really explained like what DBT entails, because I think a lot of clinicians will say they do DBT. I find it to be a little bit like, it kind of like when people say they do OCD and 500 other things, and you're like, how do you do all of that? But I think it's so important for us to understand what like a true DBT treatment approach means, and I say that because I'll give an example of when this happens a lot for us, but when people are in, we run a residential program. So when people are coming into the admissions, if we really feel like they need DBT first, we will say to them, like, we need you to go complete a course of DBT. And then the DBT clinician can let us know if they think you're ready and you're at a good place for ERP. Some of those prerequisites might be things like active self-harm and really difficult emotion regulation that it would interfere with their ability to do ERP. They've tried ERP many times, but distress tolerance has really gotten in the way of it being successful, things like that. And we'll get the question of like, oh, well, don't worry, my outpatient provider says they do some DBT work. And so like, I'm already doing DBT, I'm good. And we're like, well, how do we explain that like you need? And so maybe you could share a little bit about just like, what is that length of treatment and how does somebody go about finding those like appropriate true DBT programs that follow an appropriate protocol?
Yeah, it's tough because of what you're saying in terms of a lot of folks getting some exposure to DBT and incorporating that in, which is valuable in its own right. And if you are looking for a comprehensive model, that's one of the key words I would be looking for. So I would advise clients, patients, or referring clinicians to be looking for that word comprehensive. So in order to be a comprehensive treatment, you have to have individual therapy, group therapy, phone coaching, and a DBT team. So those are the four different modes that you're looking for. The groups, there can be some variation, but the base model tends to be that one round of the DBT skills lasts about 6 to 7 months. Many places, the original RCTs for DBT recommended doing 2 rounds of groups. So that does tend to be about 1 year, a little over a year with pretreatment. However, there is pretty exciting research in recent years that 1 round is pretty effective as well. So doing about 6 to 7 months. So in terms of like a rigorous, adherent, comprehensive program, you want to hear that comprehensive word mentioned. You want to see the 4 modes, and you really want to have a full course of treatment is going to be about 6 or 7 months of the skills groups, because that's how long it takes to get through mindfulness, distress tolerance, emotion regulation, and interpersonal effectiveness.
So helpful. And so, Lauren, I would love to hear kind of, as you've been leading so much OCD work and, so much around kind of how we effectively treat patients with OCD and have really advanced that for us in many different ways. I would love to hear a little bit just about how you've seen DBT be incorporated effectively for patients with OCD and what that looks like.
Sure. Yeah. So maybe I can speak a little bit about the order of events, and then that can lead into the answer to your question. So when folks call into the clinic or we do an intake, and if, like you said, Liz, if folks have high levels of suicidal ideation or they're actively self-harming or have had recent attempts, those are absolutely reasons that we would pause and think about presenting to the DBT team to see if it makes sense to start there. Another big barrier is if folks have a lot of interpersonal dynamic challenges that would make it hard to have that OCD therapist relationship. Because as an OCD therapist, I often feel like I'm trying to become someone's coach and pull them or push them or encourage them to do the scariest things they've ever done in their life. It's really important that they see us as a team. So if there is a lot of if there are a lot of issues with interpersonal dynamics and that's coming up in the therapeutic relationship, it might make sense to refer to the DBT team first to learn those interpersonal effectiveness and emotion reg skills. When folks come from the DBT program to us, it is so clear that they have such a wide array of skills that really set them apart and set them ahead of the pack that compared to someone that's never done treatment before. Some ways that looks is that the person has the ability to name and label their emotions, have a sense of where they are on the SUD scale or subjective units of distress scale, know what they need to do to manage intense emotions that come up outside of the therapy space or inside of the room, have ability to engage in mindfulness practice, which we know can be so helpful for anxiety and OCD and engaging in a values-based life. So having that groundwork already done is huge. It's also a pretty easy sell to keep doing exposure work or to start doing exposure work, since that's inherent to the model of acceptance and change, right? So it feels like they already know the language, even though they might not know the exact vocab for OCD and ERP. Evie, would you add anything?
I think I would leave it at that. I don't know. I'm curious to hear what the other questions were.
Yeah, no, what I just wanted to ask is, I worked with a client, for instance, who did DBT, like you said, Lauren, and when he came to do an IOP for OCD, just exactly what you mentioned. It was like he was able to do the treatment because prior he had tried to get into some other programs and there was some self-harm and some other things. So I just want to first validate what you're saying. I do agree. The question that I have is, how does somebody know, let's say somebody's watching this, obviously a lot of people connect dialectical behavioral therapy specifically for borderline personality disorder or BPD. How does somebody know if DBT is effective? Like, is DBT effective if somebody doesn't have the diagnosis of borderline personality disorder? Is it only for borderline? Could you clear that up for people watching about when is DBT useful? What diagnosis is it for, and how people can navigate that?
Yeah, so I can speak to that. DBT has been shown to be effective for folks with borderline personality disorder, eating disorder, substance use, PTSD, ADHD, generalized anxiety, some more nascent research on OCD and transdiagnostic emotion dysregulation, which frankly is kind of such a broad net that I just want to label that it becomes less useful, right? So to answer your question, okay, great. It's got great evidence for a lot of different disorders. I would say that the evidence for OCD is more sparse and newer. The way that I would think about it, which, full disclosure, Lauren and I are mucking through this together. This is not something that there's been a ton of published work on. But some of the things that I've been thinking about is when there is more straightforward OCD, and that is the clear, predominant presenting concern, and there's not a lot of co-occurring disorders that are mucking up the clinical presentation or complicating. I think starting with OCD, or with ERP work, is a great plan. DBT is very helpful when there are multiple presenting concerns that make it complicated to focus just on OCD. So when you are trying to work on OCD with a client and you find that there is just chronic interpersonal problems, when there is eating disorder, substance use, when there's anger, aggression, when there's self-harm, when you find yourself in a position that there's so many moving pieces that you find yourself continually wondering, do I stay the course with ERP, or how do I address all these other things that are coming up? DBT structure is well set up to make decisions and give clinicians a decisional hierarchy to handle kind of different presenting concerns and different problems simultaneously. However, if OCD is far and above the top concern and it feels more clear-cut, that's going to be the most efficient approach. So I, for efficiency's sake, would recommend ERP when it kind of rises above all other concerns as what needs to be treated.
Yeah, and I think that, one thing I want to bring up is that we have a pretty extensive admissions process, and I think that we do a pretty good job, as best as we can, of being able to make our best educated guesses based on the information we have of what a patient needs. But I say that just to say, I also want us to really maintain flexibility of what your treatment team is recommending as you're in the process, right? There are a lot of times where we really think it would make sense for a patient to start with ERP, or a patient really advocates for that. And, a couple weeks in, 3 weeks, whatever it might be, we might be saying, what, I really think it makes sense for you to do DBT first. And sometimes I found people at times get a little bit frustrated when I say that, but in the end, they always really appreciate it, right? Because they are able to go do those skills. And as Lauren said, when they come back, they're better equipped to do ERP. It's actually so much, you just see such a difference in their ability to retain it, to be able to engage in it, to be able to manage and tolerate that distress. So I just want to point out to everyone too, that it will fluctuate, right? We may be able to say, this is what we think makes sense, based on the info we have, but that could change. And it's really important we follow the guidance of our clinicians. As someone with lived experience, I always say, I wish DBT skills were more well-known when I first got treatment. That was 20 years ago. We didn't really have and know a lot about DBT, but I'm like, oh yeah, that would have helped me so much for some readiness work for ERP. So I think there's just so much value in us really figuring out what does the person sitting across from us need. We can't always make the best guesses up front, but it might change with time, and be flexible to that.
Can I ask a question real quick to you, Liz, and to you, Lauren? Because I have OCD, so I'm thinking I'm watching this, right? And I don't want people to think, oh, I'm going to go get DBT for OCD. So for both of you, for your program, Liz, or for you, Lauren, because you work so closely with Evie, when do you as clinicians say, okay, I think DBT is needed here? Let's say somebody comes in and does an assessment for either of your programs. I just want people watching to not think oh, I should be getting DBT just because, right? When do both of you as clinicians say, okay, I think DBT work needs to be adjunctive, or after or before? What are some of the signs during an assessment when you're doing OCD work?
Yeah, for me, I'd be looking for self-harm, suicidal ideation that includes planning. I know a lot of people come to treatment with OCD and suicidal ideation, and that typically what I hear most is, if this is what being alive is, I don't know if I want to be alive. This is just so hard. But when it crosses over to and I have an active plan, these are my means. I could access those means pretty easily. I've made attempts in the past. Those might be things that would push me towards thinking about DBT. And like Evie said, the history of interpersonal challenges or lots of anger coming up.
Same, Liz, or for your program, is it pretty similar?
Yeah, I mean, I think that it's pretty similar for sure. And I think the big thing that I will say is that DBT is not an evidence-based treatment alone for OCD. So I want us to remember that we're really talking about DBT to get people ready for OCD treatment and to address other things that are going on that are not defined as OCD, right? I had this conversation yesterday where I had to say, self-harm is not an OCD compulsion. Those are two different things. I hear that a lot where people will say, oh, my loved one has OCD and they're self-harming and that's their OCD ritual. It's like, well, no, like self-harm is not, right? Like, so we have to differentiate what is DBT useful for. Of course, just like many other interventions, right? They may benefit you as a whole, which may also benefit your OCD a little bit, right? But it is not a standalone intervention for OCD. So I want to be clear about that. I think that what we're saying is you can do a dual DBT and ERP intervention if you have OCD and you need DBT work. But if for OCD alone, we are still recommending ERP as the front line.
And I think, and I just want to add to Liz's point that I am so lucky and my team is so lucky and my OCD team that we have a DBT team in-house that is also trained in ERP. And that feels like a much safer referral than sending someone with severe OCD symptoms to a DBT program that we don't know what their training is on OCD. So I know that my folks are going to get access to a clinician that knows DBT and ERP, and that just feels really important and like such a privilege.
No, well said. I'll never forget, Liz and I were on a panel together with my mom and my sister for a conference, I think OCD SoCal. And it was just like, it was funny because in the middle of the conversation, Liz is like, you really need a DBT. And I was like, I probably did but I was mentally ready for ERP, when I did get it. But in high school, when we didn't even know about ERP or OCD treatment, I was angry. I was breaking things. I was screaming. I was yelling. I was drinking my thoughts away. Right. And so for me, I couldn't even regulate my normal emotions because of the OCD. So I do think, if people are watching this, if ERP has not worked for you and you're showing some of the signs of the things that the panel's been talking about today, this is definitely something to think about. I did want to bring in, Lauren, a question about the kind of co-occurrence of borderline personality disorder and OCD. Do we see that a lot together? And if so, how do you know which one might need treatment first, or is it something that can be treated co-occurring?
Well, we see a fair amount of it, but that's because we do both things. I'm not sure about other clinics. I'm curious about the two of your experiences with that. For us, it seemed we have this across the OCD, DBT, and trauma track where someone will come in for one, and if the trauma or the BPD is addressed, sometimes it'll emerge that the person actually has pretty severe OCD that's just been hidden by the trauma or the avoidance associated with the trauma. So I don't have numbers for you, but it's an evolving thing. And I'm curious what you think, Evie. I feel like it's pretty common for people that are in DBT to have some history of OCD symptoms, not the majority, but a fair amount that the folks on the DBT team are mentioning in case consult.
Yeah, I would agree that I think that being a specialty clinic makes it a little hard to speak to how much of that is that people search us out for that reason. But I would say in terms of what should be focused on first, I would come back to really looking at behaviors and problems rather than the diagnosis, because BPD is can look so different in different individuals. So for many folks who have that diagnosis, many of their impulsive, harmful types of behaviors may have subsided. We do see that quite a bit. And in those cases, it might be more appropriate to start with an ERP treatment and just dive right in to their top kind of target. So the question is what is their presenting concern list? And if OCD is far and away at the top, it's going to be more efficient for many people to start with ERP.
For those that may not know much about borderline personality disorder, what are the main kind of diagnostic criteria that people would look out for that potentially they have the disorder?
Sure. So there's 9 different criteria, and you need 5 in order to meet diagnosis. So that means it can present in lots of different ways. Marshall Linehan breaks the diagnoses into different areas of dysregulation. So a prominent piece is emotion dysregulation. So that can look like emotions that go up and down, sort of like a roller coaster within one day, quite unpredictable, rather than sort of a sustained level of depression or sustained anxiety. People with BPD talk about really extreme, intense fluctuations. We also see lots of problems with anger and inappropriate displays of anger and aggression. There is interpersonal dysregulation. So folks with BPD describe being swinging between extremes of idealization and devaluation of others. So lots of hot and cold relationships, extremes in relationships. We also see relationships that become really intense really quickly and then can get sort of cut off. There's often issues of people feeling frequently abandoned and having really intense reactions to perceived or real abandonment. So that's the interpersonal component. There's behavioral dysregulation, which looks like recurring self-harm and recurring suicidal ideation and behaviors, and also sort of impulsive, potentially damaging behaviors. We see things like shoplifting, stealing, lying, drinking, substance use, eating disordered behaviors, gambling issues, things like this. And then there is a sort of cognitive dysregulation cluster, which looks like issues with depersonalization and dissociation. And finally is a self-dysregulation cluster, which is, I think, a little bit unique to the BPD presentation. So folks with BPD sometimes talk about feeling like they lack a sense of a core self. So feeling like it's hard for them to understand who their self is, and that maybe it changes a lot over time or depending on relationships. And that there's also a core and chronic sense of emptiness. Sorry, that's a long answer, but there's 9 different criteria. And yeah, hopefully that touches on it.
That was great.
If I could-
Could you share a little bit about some of the skills that you find with DBT and OCD treatment that have a lot of overlap? So some skills that maybe we would use for OCD and DBT, but also some caution. So I'll give a quick example, but mindfulness, I think, is a good example of like an ACT intervention that can be really useful in the ERP model if it's used appropriately. But I don't really want a patient doing like grounding and counting to 10 and doing certain distraction techniques when they're in the middle of an exposure, right? So it's kind of that like, oh yeah, this is a great tool, and here's how we can use it for OCD that's effective versus not. Could you share some of that around some of the DBT skills?
Yes, I think that mindfulness is a big one for sure in terms of being able to make contact and have awareness of thoughts and emotions. And urges. So that can be a great one for both treatments. Distress tolerance can be important. I'm predicting there might be questions about like when distress tolerance could possibly be compulsing or could turn into sort of a ritual potentially. So I will say we kind of look at it, and some of this I'm borrowing from Adam Reed, who kind of presented and shared some of his thoughts on this, who was at McLean, who talks about like a certain zone of effectiveness. So when we think about when we might use distress tolerance skills, even things like counting, breathing, tip skills, which means utilizing ice, and various other kind of physiological interventions, distraction, all of these things could potentially take someone out of an exposure. So there is that risk. And so I use the heuristic, the kind of wanting to be in like a zone of tolerance, where if somebody during an exposure is escalating to a state where they might be dissociating or depersonalizing, or if there is self-harm or self-loathing. Sometimes we use those as cues that doing a bit of a break for distress tolerance might be important. For the most part, we try to not have distress tolerance kind of used during an exposure. And there could be a point where an exposure has gotten the person so aroused that they're no longer actually in it. So that's a little bit, I mean, but admittedly, it's just a really tricky dance. So I would say it's not something anybody feels perfectly clear on at any given time, but that's some kind of rules of thumb. Certainly interpersonal effectiveness skills are things that are somewhat additive in terms of DBT. So that can be something valuable that isn't covered as much in ERP, but things like assertiveness training and relationship building. And I would say that many of the emotion regulation skills can be helpful, especially reducing vulnerabilities. And I think this is probably incorporated in what a lot of people do in ERP. So this is things like making sure that your weekly schedule has positive events baked in, that you are doing things to foster mastery and that align with your values and relationships, so that your life is not just nonstop painful ERPs and kind of white knuckling through it. So yeah, I'll stop there and make sure others can ask questions.
That's so helpful. I love that. I love the thought process, and a quick reminder for everyone that ERP doesn't have to be painful ERP all the time, right? It should be like, ERP should feel freeing. It should feel like it's getting you to this place of freedom and recovery and what you want. And it's tough, of course, like in the sense that you're having to ride this wave of emotions, but it shouldn't feel torturous. And that's just a good reminder for us. But Chris, I know you want to hop to some live questions, so I'll get rid of my other document and take a breather.
Yeah, we'll go back and forth. I wanted to put first, it's a comment and then a question. So if you could put up Amanda Caitlin at 12:31 your time, emotional dysregulation skills are necessary to do ERP. What I wanted to ask y'all both is, like for me as a clinician, obviously I have clients that do ERP and they don't need any adjunctive treatments and they do great. And then obviously my goal as a clinician is to always have more and more tools. And so, luckily, I worked with somebody who came from the DBT Center of Orange County. I definitely am glad for the clarification that there's definitely a difference. But for some clients, the emotional dysregulation skills really, really are helpful. So what I wanted to ask is, like, when you are working with OCD, what is the presentation that you think, okay, some emotional dysregulation skills would be helpful, and clients or individuals with OCD watching this, when should they start to ask their therapist about, hey, I think I might need some emotional regulation skills because I'm really struggling with ERP?
Yeah, some things that I look for are, as Evie was mentioning, dissociation in exposure, or a sudden spike in thoughts of I want to die right now. So huge spikes in thoughts of death or suicidal ideation, dissociation. Another one that we talk about a lot is sadness. So this could be when there's an overlap of OCD and a history of trauma or BPD or something else that's bringing up a lot of sobbing and sadness in exposure, not so much anxiety. So when another emotion, anger, sadness, dissociation, becomes the focus of the exposure or the result of the exposure, we sometimes use emotion reg and mindfulness skills to bring the person back to the anxiety and focus on that as the goal of the exposure. And if we are using emotion reg or distress tolerance skills in exposure, we want to reduce that over time. The goal would never be to always stay there. The goal would be to reduce the need for those coping skills or regulation skills eventually.
Awesome. The next question was from 1232 Amanda. It says it's from Josh, and if you have time, would you be able to speak a little bit about differential diagnosis between borderline personality disorder and autism in the population that you serve?
Yeah, that's a complicated question. I would say that with folks with borderline personality disorder, There tends to be really prominent issues with identities. So shifts in, how they see themselves, what their values and goals are, what their preferences are. So that's one thing that I wouldn't say that I necessarily see as much in autism. A big asterisk and caveat is that those types of concerns are pretty common for adolescents and young adults. So we never want to over pathologize sort of normative identity shifts and exploration. And I think that the interpersonal dysfunction is pretty specific in DBT. Folks with autism, obviously there's a lot of different ways that autism shows up, but it's a bit more common for folks to talk about difficulty understanding social cues or making sense of what other people are trying to say, or feeling kind of like anxious or overwhelmed by emotional information within relationships. In my experience, folks with borderline personality disorder are actually incredibly attuned empathically, almost to a point where it causes harm. So they are very attuned to reading between the lines of what people are saying. They are very attuned to others' emotions. They read people like a book often. It's like almost a superpower sometimes. And that can almost cause dysregulation because they're too attentive to others in a way that is kind of dysregulating to be that clued in. But so that's a big one that's different, I think, is that interpersonal piece in particular.
Another thing that I've seen is folks with autism and OCD could feel so anxious that they say things like, I want to die, or I just want to kill myself. And when we dig deeper, it's really about naming an intense emotion. So it's like, that's what a 9 or a 10 feels like. And that's the only words they have to describe it, as opposed to it being more of a BPD related self-harm history or ideation history that persists throughout the day, ebbs and flows with emotions, but is more stable. So I think if you're working with someone, or you yourself are experiencing those thoughts of death when you're very anxious, or the client's very anxious, I'd encourage digging a little deeper to figure out, is that just how you're describing the scale of emotion, or is it actual desire to die?
Thank you.
Sorry, I can't toggle between questions and screens right now. But the next question that I think is really good is, how do you know what distress tolerance skills to use in the context of an OCD trigger? So I'll give an example, but when I was a much younger clinician, I would use dive skills a lot, and like, oh, just use a dive skill. And I really learned that, like, okay, and we could talk about what those are, but there's times that dive skills can be really useful. But then also there was times where I actually wasn't always teaching my patients how to handle distress in the OCD context. It started to backfire sometimes, where it was like, oh, they're actually now relying on a dive skill to regulate versus being able to weather that anxiety storm for OCD and ERP purposes. So I would love to hear a little bit about, like, when might you use those skills in an OCD and ERP context, and when we be like caution them? And maybe if you could give just an example of 1 or 2 specific skills, either of you would be great.
I think in general, I try to vary the types of skills rather than there being a specific one. I think about trying to have an array of skills so that folks are able to flexibly use them, rather than saying every time this happens, I'm going to put my face in ice. Because I can see, to your point, that could start to feel like a new ritual, or it could start to feel like avoidance. Other things that run a little bit less of a risk of some of our skills that are, either tip, or we have an entire suite of skills that are about distraction, can be ones that rely more on reminding oneself about meaning, for example. So that's one of our improved skills. Self-validation and cheerleading. A lot of these things parallel our non-engagement responses and things that you might already see within ERP. Self-soothing skills are about using sensory input in order to sort of take the heat down a little bit without necessarily totally removing an anxious stimulus. So those can be things that run a little bit less of a risk of kind of jolting somebody out of an exposure entirely and could just take the temperature down. So I would tell people to look into self-soothe skills in particular. Lauren, I don't know if you'd add things though.
Yeah, I would just add that asterisk that if that's where we're starting, because that's where we're meeting the client where they're at, I would build it into a hierarchy to reduce those skills over time, the use of those skills to get through the exposure. Another thing, this isn't exactly a distress tolerance skill, but one of the skills would be paced breathing. I don't use paced breathing in exposure, but what I do sometimes do is remind clients to be breathing. So when we do Jello mode and try to have a relaxed body position and willing hands in the face of severe anxiety or intense triggers, I also want to make sure that the person is relaxing their chest and in doing so breathing while they're doing it, not to calm down, but to model that there is no danger here, or to model opposite action in response to a fear stimuli, as opposed to white knuckling and holding one's breath.
Exactly. Yeah, no, it makes total sense. So, I would love to hear a little bit more. You shared a little bit about some of the specific things that you notice when somebody comes from a DBT program to an OCD program, but what in particular might that look like? And then I want to tag on to that question. We're getting a lot of questions in the chat about how people kind of pick somebody to do DBT treatment, if they, and some folks feeling like it isn't always useful if you need DBT treatment, but you have OCD, if you're seeing a DBT provider who doesn't understand OCD, and that sometimes it can be hard. And so would love to hear a little bit about like why that might be kind of important and what that would look like, but then also, I don't know, how those skills translate. We've talked a little bit more about that. So let's kind of transition to how would you find a DBT provider who would be effective or that we would recommend and maybe that's still like OCD informed.
Ooh, that's such a tough one. I mean, I always like the IOCDF Find a Therapist tool as a way to filter people. So if you are to find someone that maybe on a website says they do OCD work and DBT, maybe checking to see if they're also on the IOCDF website to see if they are in the community at all. And that would give me some slight confidence that maybe they're following the research. Looking for folks that are Linehan board certified, like Evie is, would be a way to look for that quality of DBT therapist. I'm looking for folks that are BTTI certified or trained would be another way to find that. But I think in a lot of cases, they are unicorns. There are people that are really drawn to OCD work and people that are really drawn to DBT work. And we don't normally have clinics where people are doing both. Maybe hospital settings might be good because there tend to be more unit options and maybe the potential to transfer or cross-pollinate across departments.
Yeah, and I think one of the things that I keep hearing as the theme is it's important to find somebody that is informed in OCD work as well, because often we know that sending someone to somebody not completely understanding OCD, things can become, you talked about it a little bit earlier, Liz, and I've seen this with clients, is where some of the DBT skills that they learn are super helpful for other things, but then they've used some of them compulsively, or they just don't seem to work, or things like that. So I'm glad you keep bringing that caveat up. But I would say, let's say somebody can't find, would you all agree with this? If you can't find somebody, unfortunately, who has you guys are a center that is definitely a unicorn, speaking of unicorns, because there aren't a lot of OCD and DBT centers together that are really, really informed on each other's modalities and understanding of obsessive compulsive disorder. If people can't, is it something where you could have like a team approach where your OCD therapist may talk to the DBT therapist and really collaborate to ensure that there isn't something going on that's potentially impacting the success of ERP?
I think that would be ideal. There is a little bit of this is getting a little in the weeds, but as a DBT therapist, I typically wouldn't have somebody have a secondary therapist. So, yeah, I think that my recommendation might be, given what you're saying, given the reality that there is a sort of a dearth of kind of dually trained providers or clinics with both, would be probably to either screen. Unfortunately, this does rely on a lot of self-advocacy, so I want to acknowledge that is a hard thing. But to screen and ask a DBT provider how they would handle doing ERP and how they would handle the potential for distress tolerance becoming reassurance, and just be really on the lookout for somebody who understands how to answer that or who shows some evidence of thinking about it. If I had to prioritize, if it was my loved one or somebody I was taking care of who OCD is clearly a prominent concern, I would probably recommend prioritizing an OCD expert and perhaps considering finding a standalone DBT group in the community, because what I've been describing is a comprehensive program, which for folks with certain clusters of problem might be the priority, but for many people, it might be helpful in its own right to have a standalone DBT group. And those are easier to find. In terms of many local hospitals, universities, and clinics will have standalone DBT groups. So I don't want to downplay the potential helpfulness of doing that alongside working with an individual ERP provider.
Yeah, and again, I want to just reiterate that if you're with an ERP provider who is ethical and who you trust and you have a good working relationship with, right, they should be able to help guide you if this makes sense or not for you, or if you need something more, if you need something different. And so those are just all things to keep in mind, that again, our job as clinicians, but like as individuals, is we're really learning flexibility in ERP treatment and DBT, right? Across the board, that's one of the biggest skills we're learning. And so can we also have that, with our treatment protocol, or what might make sense for us from a treatment perspective. So I love this. I feel like this has been such a helpful overview into how DBT and ERP can go hand in hand, but also why we might treat one first, and Chris and I have talked about this before, and you can go to the YouTube channel for Add-on OCDFs, where we've talked a lot about why and what might be some things that would make you say, okay, I need to do that as primary first. But it's one thing when y'all hear us talk about evidence-based interventions, what we mean by that is, what is treatment that's backed by research? What is treatment that we know is the most successful or has the strongest and highest chance of helping you with whatever you're dealing with? But with that being said, we talk a lot about how most of what I see cases of OCD may be comorbid with another condition. And if that condition is a personality disorder, DBT is the evidence-based intervention. If it's trauma, right, there are trauma-specific interventions, CBT, CPT, and EMDR, that are evidence-based interventions. And so it's just a quick reminder for us to say, like, these DBT skills can be really useful in an OCD lens, but also if you have a comorbid diagnosis, if DBT is the evidence-based treatment, it is critical that you do DBT first or simultaneously. You cannot say, oh, I'm just going to do ERP and ignore my other stuff going on, because what we know is that, like, it will impact the outcomes of ERP and it will need to be addressed later, if not primarily, right? So again, think a lot about comorbidities. What is the evidence-based intervention? And what I love that was brought up today is that if someone's presenting with pretty clear OCD and they aren't struggling with things that might warrant DBT first, we would still say ERP alone, right? ERP first. That's what makes the most sense. We might change that as we learn more about the individual we're working with. But again, what are we struggling the most with and what's primary? And the thing I want y'all to think about is that if you find, I will hear people, excuse me, say things like, ERP doesn't work for me, or I can't do ERP, or I can't tolerate ERP. Therefore, they want to go try a different intervention for OCD. Sometimes that actually might be an important place to step back and say, okay, why can't I tolerate ERP? What is getting in the way of ERP working for me? And instead of throwing ERP away, I would encourage you to think about, is there something else going on that I might need a different intervention first? And I often see this as being DBT, especially when I see emotion regulation and different things that come up that prevent someone from being able to effectively do ERP. So that's my spiel, but I just have loved having you all on. I know that our viewers have too. We have lots of other questions that we didn't get to, so I'm hopeful we can do a round 2 where we can dive more. This was kind of an overview of DBT, ERP, how they work in isolation and hand in hand, but hopefully next time we could get into some more of the nitty-gritty questions if y'all are up for it. Chris, I'll let you take it away, and then Lauren and Evie, we'd love for you to end today with some final thoughts about how you integrate both and why it's so important that we're doing that for a lot of our clients.
Yeah, no, I'm like I said, I'm always excited about the lunch. I wasn't as talkative today because I was more intaking and learning, and I think it's super important. I mean, I learned a lot of things today. I hope the main thing people heard is what you were saying earlier, Evie and Lauren, is that DBT isn't like this DBT skill things you do. It's a very systematic approach. There is a lot of components to it. And if somebody's watching this and let's say they've been like, DBT failed me, right? Did you do it in the way that was described today? I know from a coworker, I mean, it's not a little thing. I mean, you have the groups and you have the calls and everything you talked about. It's usually at least a year process. So make sure if you're doing DBT, you're doing it the correct way that you heard today on the live stream. But I would say the other thing that I really learned today is that, Liz kind of said what I was thinking, is that a lot of times when people come in and think, okay, I have to change the way that I'm addressing my thoughts, I have to change the way that I'm behaving and start to re-engage with things that are passionate to me, but it's causing so much angst and I want to just shut down. Watch this again, watch it back. If the things that were talked about today really kind of hit home for you, DBT may be a perfect skill that can then help you with your OCD treatment. So I just hope people heard and took a lot like I did in, and I thank both of you for lending your expertise. But we want you to end us off with some final thoughts. So I'll let you both take it away. You guys can decide who gives the first final thought.
Evie, you can go first.
I will just second what Liz and Chris have both said, which is that there is quite a difference between doing a full model DBT program. So if you are facing problems consistent with borderline personality disorder, if you have chronic emotion dysregulation, self-harm, suicidal behaviors, I highly encourage you to, unfortunately, do a little legwork. You can always look at the Linehan board certified list or look up the terms comprehensive DBT because it does make a difference and it dovetails really beautifully with ERP. A lot of the principles and concepts are the same. And so hopefully it can marry well with what you've already learned or what you will do next in terms of an ERP focus.
I would just end thirding all of that, a lot of folks say I haven't done ERP, or I've done ERP, it didn't work for me, or I did DBT, it didn't work for me. Well, did you do ERP with ERPs in session for 3 months, or was there one ERP in session and then it became a check-in? So making sure that you've tried the treatment by the book before giving up on it completely. And I did want to leave folks with another resource that clients can read or providers can read to learn a little bit more about how they can use skills across. And that's a book called The Unwanted Thoughts and Intensive Emotions Workbook, CBT and DBT Skills to Break the Cycle of Intrusive Thoughts and Emotional Overwhelm by Dr. Hirschfield and Gary.
Yeah, Amanda, if you have a second, if you could put that link, Lauren put it in the private chat. That's a great book that I feel is like a good crossover what we did.
About it.
Yeah, I also, Amanda, if you could quickly, I just put a YouTube video. There was a question earlier from JWN99, who's joining us from Twitch. It's his first time. They had a question about TMS, and Liz and I just did a live stream with Dr. Sanjay Saxena, and we did cover TMS, so please watch that. As for your other question, we didn't get to it this time because we were kind of focusing more on DBT in this topic, but Liz and I will be back in 2 weeks because next Wednesday is Research Roundtable, but following that, we're doing more Ask the Experts. So JWN and others, if we didn't get to your question, please join us in 2 weeks. We're here every Wednesday except the second Wednesday, 9 my time on the West Coast, 12 on the East Coast, where I know Evie and Lauren are both enjoying their life. So make sure to join us back and we can answer your question, and hopefully the resources we put in the chat the TMS question, but definitely check out the book. But yeah, thank you so much for both being on and sharing your expertise and skills. And I know a lot of people will watch this back and get some clarity about what specifically is potentially could be helpful. I learned a lot, so thank you so much.
And thank you for
100%.
having us.
Y'all.
Hi.
Oh, and I know we haven't totally gone off yet. So where can they find y'all?
Oh, well, if you Google Genesee Valley Psychology, you can find both of our programs. We're both in private practice, seeing individuals at Meridian Psychology Practice, which is also Googleable.
Amazing. Thanks, y'all.
And JW,